Okay, forward head, typical presentation, student posture. Okay, so what I try to do is kind of get a little bit of that lumbrical grip. Okay, but I tend to flex my IPs just so it's not so much of a pressure into the back of the head. I go right to the base of the occiput, and then I just rest my hands right up into that suboccipital space. Is that painful? Okay, and I just try to get people to relax.
How long do you just sit there before you feel relaxation?
Usually about 2 or 3 minutes. You know, so I'll just sit here, hang out. How's your day so far? Plans for the weekend? The weather's supposed to be pretty nice and hot again. Okay, so right away I can feel if she's guarding, right? Because she'll pick her head up, she's relaxed. Okay, is that pain presentation changing at all? Okay. So I'm looking for what as I do this? Looking for symptom modification, right? I want to see that there's some sort of change in her pain, and then from a clinical sign perspective, I'm looking to see if I don't see a decrease in that tightness. It's not an immediate thing. I'll hang out here for usually a couple minutes if it's comfortable for her. My hands tolerate it. If this was an effective way to decrease some of that upper cervical tightness, what's an easy way that I could teach her to do this at home? Tennis ball, right? I can have her get a tennis ball. I can have her get 2 tennis balls, put 2 tennis balls in a sock, tie off one end, and then I have essentially a set of hands, right? I can get that right at the base of the skull. Any pain at all? Okay, so just a really easy, straightforward technique. You do that by itself or in isolation with other things. And that's suboccipital distraction. Upper trap stretching, you know, a lot of times what I like to do is take them to end range, apply a little bit of pressure. Any pain with that at all? Okay, I like a lot of contract relax too. So I'll have them do one of 2 things. Go ahead and bring that right shoulder up into my hand. 2, 3, 4, 5, relax. Okay, take that a little bit more, or I can come in here and do both. I want you to do some right side bending and shoulder elevation at the same time. Okay, so I can have her side bend to the right and elevate that shoulder and really shorten upper trap at both ends and see if I don't get a better relaxation response. Is that painful at all? Just a big stretch. Okay. Scaling is pretty straight lateral flexion. Yeah. Yep, levator could be rotation. Typically, upper trap isn't as much rotation. Side bending. Side bend to the right. Rotate to the right. I'm stretching the right side. So I want her to side bend. Contract, relax. We're shortening the muscle. Okay.
Trisha, the side that's being lengthened,
Yeah,
he wants her to contract.
So from here, just having her either shrug the shoulder for me on that left side. Good. Okay, relax. Or what I'll do a lot of times is I'll just bring my forearm into it and I'll say go ahead and side bend left and shrug your shoulder. So she's pushing into my forearm and elevate that shoulder and relax. And see if I don't get a little bit better stretch out of that. Typically I do, just a little bit. Through what?
Is there rotation or is it just
A little bit of rotation. 15 degrees. Okay, manual distraction. Okay, you can do this any number of ways. You can do it with a strap. What I'll do a lot of times is I'll take my dominant hand, because I'm right-handed, left hand stupid, and I'll grasp the lower part of the occiput. Okay, I'll use my left hand just to more or less reinforce that grip. Okay, I'm not doing a Vulcan neck grip on her. I'm just trying to get a good firm base, and then I don't use my upper body. What I do is just lean back away from that. Is that painful at all? Okay, so I'm not using, I can do just a straightforward distraction. I can do oscillations. Another way you can do it is I can come in, I can put my hand on top of her head and lean back that way as well. So however you like to do that, just make sure you're not doing this to the back part of their occiput. So I'm just coming in, using more of, sort of like a lumbrical grip. Her occiput is resting right on my thenar and the lateral border of my hand. And then I'm coming in with my other hand, almost like a cradle hold. And just using that to reinforce that. My dominant hand. is the one that's getting on the occiput. My left hand is just a supporting hand. I may not understood your question, I'm sorry.
What technique are you using?
Suboccipital, I'm sorry, not suboccipital, cervical manual distraction.
So how is that different than the suboccipital distraction?
So suboccipital, we're just going at the soft tissue, and we're just utilizing more of like a myofascial release. Long axis distraction or cervical traction, we're getting at the occiput, and we're trying to utilize a mechanical force to pull those vertebrae apart. Just like that.
Okay, so with the suboccipital distraction, you're not actually pulling towards the
No. Just put pressure over. Okay, let's go on your stomach for me, please. Okay, central and unilateral PAs are no different. Okay, so central PA, I like to use a 2-finger approach in the C-spine. I'm going to go on either side of the spinous process. I'm going to use my other hand. Okay, and I'm not going straight P to A. I'm going to go into the plane of the facet towards our eye, that 45-degree angle. Okay, so there's central PAs, and then unilateral, I'll usually use my thumb, come over to one side of the lamina, and same type thing. P to A in the plane of the facet. Okay, let me skip back down and we'll roll over here. Okay, we'll come back to passive mobilization for headaches and for the COC1 long distraction. The only other thing I want to review from yesterday is the side glides. So side glides again, I look at a range of motion assessment, I see some sort of restriction. I come in, I'm using my first MCP to do my side glide assessments, okay, C2 to C7. I'm seeing what translates in neutral, okay, what translates in semi-flexion, and then what translates in semi-extension. Okay, I can also utilize that assessment as a treatment. So I can come in and say we have a loss of that side translation, and I want to start off with the lowest form of intervention. I just want to do side glide mobilization. Excuse me today, my allergies are really kicking up. I just want to do side glide mobilizations. So the same type of approach that I use for the assessment, I can make into my treatment. So I'm just going to come in. Usually what I'll do is I'll put them into a little bit of lateral flexion towards that restriction, and then I'll just come in and do oscillations. Just like if we were doing P to A, utilizing my first MCP over that articular pillar, side translating towards the restriction. Okay, I'm going to go left to right. I'm going to put her into a little bit of right side bending towards that restriction, and I'm going to come in just over that articular pillar and mobilize in the direction of the restriction.
Is this the passive mobilization for headaches?
Nope, this is side glide mobilization. No, it's okay. Questions?
Where's the restriction?
So let's say we had a restriction. Do you have any restrictions? Let's have you sit up and take a look. Let's make something up here. How about over here? Let's look to the right and to the left. How about looking to the right first? Okay, and then how about to the left? Okay, she's a little restricted there, especially going to the right. One more time to the right. Okay, and then to the left. Okay, a little restricted to the right. So let's look at that. Is that lower cervical or AA? How do I know the difference? How do you know the difference if it's coming from lower cervical or AA? You go to a meeting right now. How do I know the difference? Okay, so I'm going to put her into full flexion, okay, and I'm going to look at her rotation. Is that limited at all? It's pretty darn good to me. Okay, let's get her in supine and let's look at that now. There's that limitation again, right? I can go all the way. Is that painful at all? No? Okay, so let's look at those translations.
So is that lower cervical for supine?
You got it. Thanks. Okay, I would say C3 on C4, she's not translating as far to the left. Okay, so I'm not going to get into the biasing and all that mess. What I'm going to do is say she's not translating to the left, C3 on C4. I'm going to come in, put her into a little bit of side bending, and I'm just going to mobilize into that restriction. Okay, so I'm mobilizing right to left into that restriction and seeing if I can't improve that. Okay, if that doesn't do it, then I can look at that up and forward mobilization or that up glide. Okay, so for that, the restrictions on the left side, I'm going to flex C3 on C4. I'm going to side bend to the right. I'm going to rotate to the left. And there it is right there. I can feel that. You okay? Okay. So if I'm there, I can then come in, okay, I support her head, and then I can do that mobilization towards the plane of the facet and towards that left restriction. Just like that. Okay, so say she's restricted on the right for you guys over here. Get her to that position. Okay, this hand is kind of steering. My left hand is doing the driving. My third digit is on the base of the occiput. My first MCP is on the articular pillar where I want to mobilize. Okay, I got good support there, and then I'm going to move into that mobilization direction, up and forward. Rotate to the right. We're going to open, close, open. I got to get that right facet. If it's a right restriction, I got to get here, right? Correct. So if I close, open, close, I'm going to lock that facet down. I want to open, open, open. Questions about those at all?
So, is there any way to know? So, like you said, a restriction is she wasn't translating to the left. So you felt that doing your.
Do my assessment.
Is there any other way to do that? Since like we're not super experienced palpators to know.
Yeah, I think it's pretty apparent when you start doing those assessments because as you're gliding the facet right and left, you're looking for symmetry. I would expect that if I were to go C3 to C7 for her, I would see what appears to me to be symmetrical translation. When I see that, it's like I'm hitting a brick wall. And then I need to do something to move beyond that brick wall, whether that's the side glide mobilization, whether that's that up and forward mobilization, whether that's a muscle energy technique, or whether I get into actual manipulation. You know, I need to do some sort of intervention to move beyond that restriction. But I don't think you have to be a super experienced palpator to appreciate the difference. Other questions at all? Yeah.
How did you know if it's an opening restriction or closing restriction?
Great point. Okay, doesn't matter. It's what the osteopathic literature would tell you. You can bias it towards that semi-flexion, semi-extension. If that restriction gets better in flexion, would that be opening or closing? Okay, opening, or if it gets worse in flexion, or if it's worse in extension, then it would be closing. But if you look at a lot of the literature surrounding this kind of motion testing, we're not as good as we think we are. But it's a way to assess restrictions and then treat them. So I think it's an easy way to conceptualize biomechanical movements in spine. Okay, that's a really good question. So how do I know? I'm that good? No. I think the cervical spine, you have a little bit more specificity because our vertebral bodies are a lot smaller and I can localize with a lot more certainty. I think you still get that. I mean, if I'm mobilizing C3 on C4 or I think I am, or I'm doing